If you'll permit me today, I'm going to go through some reflections as I look back over my life, and I look back over cardiology, and I look back over medicine in the world. And I'm going to share some of these thoughts with you. It's very clear that we have made a remarkable reduction in ischemic heart disease mortality over the past 3 decades. It has progressively declined. You can attribute this to many things, the mechanical treatment of coronary arteries, the medical treatment, the coronary care units, the thrombolytics, whatever, but there has been a tremendous improvement in mortality, and in the same time, and I've used this slide before, we have seen a logarithmic increase in knowledge that's occurred in this past half a century. Those stars at the bottom left here are when I went to medical school and graduated. And I think you can well say that the whole real history of what we know and what we do has occurred within my lifetime in medicine and cardiology. I entered this world in the 20s from Buffalo, New York. It's a city currently best known as the home of the only NFL team that's never won a Super Bowl. And now I've moved to Houston, and we may do the same thing. We've never gotten to the World Series, and we may never get to a Super Bowl. What was going on in the 20s when I first entered this world? Well, Sir Henry Suter split the mitral valve with his finger through the atrium. You probably didn't know that. You thought Dwight Harkin and those guys were first. Henry Suter was first. The first clinical approach by Maud Abbott to categorizing and understanding congenital heart disease. And Parkinson and Bradford described the sequential serial changes now that we consider those of an evolving acute myocardial infarction. While Einthoven invented, if you permit the word, the electrocardiogram back in 1903, he did not win his Nobel Prize for it until 1924. I think if we put the leads on in this fashion, as you see in the bottom right and left corner with the arms or legs in a bucket of salt, we might get the leads reversed less frequently than we do in this hospital. Because I think if the technician looked at the patient and said, well, that's their left leg or their left arm, they might get them on correctly. Now, the year before I was born, there were 425 electrocardiographic machines, Cambridge machines, in the whole country of the United States. And you can see they were making a big living up there in the Northeast. There are a lot of machines up there. Lindbergh flew across the Atlantic in 33 hours and 29 minutes, solo flight. Now you can do it in a Concorde in about 3.5 hours. Sir Alexander Fleming, by observing a chance occurrence while he was away on vacation, discovered penicillin and opened the era of antibiotics, which has made all of cardiology possible, heart surgery, the treatment of infective endocarditis, et cetera, et cetera. And the year, actually 3 years after I was born, Forsman passed a catheter up his own arm into his right atrium, the first time a catheter had been advanced in the right atrium. He went down 2 flights of stairs with the catheter dangling out to get this x-ray to preserve it for posterity, and when his boss saw what he had done, he threw him out of the German university, allowing there was no place for circus acts like that. Forsman became a urologist. He won a Nobel Prize in '56 with Cournand. Probably another thing that shaped my life is the fact that 3 years after I was born, the stock market cratered. Black Friday, October 25th, 1929. And between 29 and 32, the stock market fell 89%, down to a low of 41, from a high then of 386. It didn't regain 386 until 1954, which is quite amazing. So, you know, I started my life when the stock market's crumbling, and now I'm beginning a retirement, wondering if I'm going to have to come back and either pump gas or get a job. What went on in the 30s? WPW, described by Paul White, Wolfe, and Parkinson. That's one of the syndromes where all three guys got their name in it. Many syndromes leave out some jockey in the middle. Wolfrith described the fourth heart sound and said it was due to resistance of ventricular filling. Goldblatt tied off or narrowed the renal artery and created hypertension. The first cardiac angiographic films were made in Havana, Cuba by Agustin Castellanos. And the first successful closure of patent ductus, 1938, the beginning of the beginning of then closed heart surgery, but surgery for congenital defects. Masters described his two-step test, which at first was a functional test. It wasn't even an electrocardiographic test at first, but it was a measure of function. But it became one of the origins of what we now call risk stratification. Blumgart and Schlesinger, and everyone refers to these two. This guy Davis always gets forgotten. He's never mentioned. So you got to watch where your name is on an article. If you're in the middle or at the end, you get left off. But they made very significant observations on autopsy hearts. They injected coronaries with colored lead agar, and they demonstrated that there were small intercoronary anastomoses or collaterals in every heart. These were about 40 micra or less. And if there was an occlusion or obstruction, much larger coronary anastomoses occur. And in relating anatomy to symptoms, they demonstrated that angina of effort was caused by coronary narrowing and infarction by occlusion. We know that now. We take it for granted, obviously, but this was a new discovery in 1940. On the world scene, Adolf Hitler had marched into Czechoslovakia, and Prime Minister Neville Chamberlain, meeting with the Germans in 1938, appeased Hitler at Munich, and it's probably the biggest example of don't appease the terrorist. World War II broke out 1 year later when Hitler invaded Poland, and Great Britain declared war on Adolf Hitler. The neutralists in this country were strongly against, they were supporting the war in Europe, but did not enter it until the Japanese bombed Pearl Harbor on December 7th, 1941. I was 15 on that day, and I can remember that there are certain days in one's life you remember where you were, what you were doing, the exact time something happened, and I can remember that very vividly. Roosevelt called it a date that will live in infamy, a statement that has persisted, and he used that in his address the next day. The Arizona was among 8 damaged or destroyed battleships, 188 planes down, and actually only 2,400 people killed totally. More than that were killed at ground zero a little over a year ago by the terrorist invasion of this country. Roosevelt declared war against Japan and then subsequently against Adolf Hitler the day later, and you see him signing the declaration of war. It took a couple years before the Allied forces worked their way through North Africa, Sicily, and Italy, and finally, under the direction of Dwight D. Eisenhower, invaded the beaches of Normandy on June 6, 1944. I began medical school. I began pre-medicine in July of '43, and with the acceleration of the war, 5 semesters later, a year and a half later, I entered medical school. So that was pretty rapid. There was very little time for anything extracurricular, and I was not unique. There were other of my colleagues of the same age that pursued that same course. You're looking at the University of Buffalo School of Medicine before it became SUNY. That was a 3rd school. The school was founded by Austin Flint, who was the first dean and co-founder. He was the Laennec, if you permit, of the United States, the greatest sculptor. The first school was in a church, the second a much more formidable building, and the school I matriculated in on the bottom left. The library I remember very well, and the tapered seats, a very poorly heated lecture hall, and on July 2 or 3, 1945, when we started our first day, we literally froze our backsides off in that medical school. It was not much longer after that, February 4th, that the three people here, Stalin, Roosevelt, and Churchill, met in Yalta, February 4th. Note carefully the cigarette in Franklin Delano Roosevelt's fingers and the cigar in Winston Churchill's fingers. Roosevelt had severe hypertension, and he died some 2 months later of a massive cerebral hemorrhage with blood pressures that they recorded of 240 over 120. Actually, the doctors said that he had blood pressures in the high 200 to 300 and diastolics 140, 150 many times. There was no treatment then for hypertension, and they actually felt that it was important to keep the blood pressure up to drive blood through the narrowed cerebral cortical arteries. So you can imagine what decisions he made at Yalta with his brain. 11 months after the Allied landing at Normandy, VE Day was declared when the German forces surrendered unconditionally in Europe. And after 2 atomic bombs were dropped on Hiroshima and Nagasaki, the war came to a final conclusion in the Pacific, and the final treaty, absolute surrender, was signed on the USS Missouri on September 2nd of 45. These are things in history that are, before most of you were born, but all of them in one way or another shaped my life and the life of those who were alive at that time. These are 4 different excerpts taken out of the text. And if you look at your current textbook of cardiology, it's so thick you can't lift it. Levine's text was about ½ an inch thick. There wasn't much to write about in 1948. He commented that specific measures of therapy in the treatment of coronary thrombosis, and he was using the word thrombosis, which is what we call it then, are difficult to appraise. Well, he's right. There was no therapy. The only drugs we had were morphine, oxygen, digitalis, and nitroglycerin. Nothing else existed at that time. The admonition to keep people at rest for 4 to 8 weeks and occasionally longer, although Dock and Harrison were beginning to preach the chair treatment of myocardial infarction. And there was a general tendency at that time to tell people to take the year off. Work is tough on you. It's bad. Claude Beck in 47 not only was working with some of the earlier techniques of revascularizing the heart, poudrage, tying the coronary sinus down, narrowing it, putting arterial blood into the coronary sinus, etc. But he also developed and used direct DC cardioversion to treat ventricular fibrillation. This was done on the open chest, directly on the surface of the heart. And this is alleged to be the first patient documented surviving after direct current countershock of ventricular fibrillation with the open chest after cardiac massage back into sinus rhythm in 47. In the late 40s, Frank Wilson developed the precordial leads, and it was still the case in the early 50s that you'd order an electrocardiogram, you got 3 leads and a CF4, and if you wanted all these extra leads, you ordered with V leads or with precordial leads. It was a special request. Cardiac surgery was beginning to wake up at that time. Crawford repaired coarctation, Blaylock shunt, pulmonary valvotomy, mitral commissurotomy. Bailey, Harkin, and Brock almost tied each other in late 1950, almost at the same time in separate Philadelphia, Boston, London, in finger commissurotomy of the mitral valve. Weinberg procedure, plugging the internal mammary into the myocardium to get blood flow. And Huffnagel's original valve for aortic regurg. That valve was placed into the descending aorta, and of course it treated about 60% of the regurgitation, but it made people 60% better, which was better than no better. The problem with the valve, it was plastic, and when these people walked around, they were clacking. It sounded terrible. But Hufnagel would say, well, it's better than not hearing it at all. Lillehei invented cross circulation, where he used a donor to pump for the surgical patient. And then Mayo Gibbon and others developed pump oxygenators and opened in '53 the whole field of open heart surgery. I was commissioned into the U.S. Army Medical Corps in 1948. I interned in Buffalo and was fortunate to do my medicine residency at Walter Reed, which I considered the best in the Army hospitals. The Korean War broke out in 1950. The North Korean forces crossed the 38th parallel and actually pushed the South Korean and the minimal initial American forces back to a very narrow perimeter around Pusan. President Truman committed U.S. troops almost immediately to reinforce a UN demand for North Korean forces to withdraw, and I would point out that he did it without congressional mandate. And on July 7th, under Douglas MacArthur, the UN command was created. I served in Korea in '52 and part of 1953 at the 11th Evac Hospital, which had served with distinction in Europe during World War II. The 11th Evac was at Wonju, and Wonju sits up here. I can't quite see it, but I suspect you can. That looks like Wonju from the side. We supported three hospitals north of us, 3 MASH hospitals, and we're fortunate. It was a 500-bed hospital under canvas. A surgical research unit was assigned to that hospital when the front line stabilized, and it was put there to study the physiology of trauma. It was recognized that there was a lot of post-traumatic renal shutdown, and GIs were dying of acute renal failure. And one of the artificial kidneys at Walter Reed was brought over to a position about 20 miles behind the front, and patients were dialyzed on a twin coil Kulf kidney. At the same time, we were experiencing an epidemic of hemorrhagic fever in South Korea, and its most fatal event was the hemorrhagic destruction of the kidneys with renal failure. And these young kids also profited from renal dialysis, and a good number survived. We didn't know then what caused hemorrhagic fever. Now you know it's a hantavirus, which in the southwest of the United States is mainly a pulmonary infection. But the hantavirus in South Korea was mainly damaged the kidney. These kids came in just red with a red rash and high temperature, and with renal failure died rapidly without dialysis. We had a remarkable staff at the 11th Evac. These young people, Holly Smith ultimately became chairman of medicine at UC California, San Francisco. Bob Abernathy became chairman of medicine at University of Arkansas. Paul Teschan, renal section, St. Louis. Carl Pearson, who has since died, head of the rheumatology section at UCLA, Irving Huffman in cardiology at SUNY. It was just a remarkable place to practice medicine under canvas while a war was going on. We did collect all the ECGs on patients with hemorrhagic fever, and after Carl Pearson and I got back to the States, wrote a paper on the electrocardiographic findings in hemorrhagic fever. At the same time, some pathologists in Japan were looking at the hearts of young GIs killed in action in Korea, and lo and behold, at 18, 19, 20, there are already coronary arteries that may be severely occluded. This came as a new finding and a little bit scary. Before I put the answer up, I asked you to say to yourself who that is. Do you recognize him eating from a mess tray? Well, that's President-elect Dwight Eisenhower with the 15th Infantry Regiment. He was already elected in November, and he made a quick trip to Korea and promised the troops that he'd put an end to that war, which he did. The South Koreans used the picture of Ike that was on Time magazine a month or two before, and there are pictures of Ike everywhere in South Korea. Ike took on a more Asian appearance in those pictures as they were reproduced, but it was still Ike and wonderful. The ceasefire was signed July 27th, 1953. That little bitty war, there were 54,000 Americans killed and 250,000 South Koreans killed, and probably 1 million or more North Koreans and Chinese. I had the good fortune after the war to get back to Walter Reed, which I've always considered my personal mecca, and to work with Tom Mattingly. I had worked under him when I was a medical resident. Tom was chief of cardiology and was gracious enough to accept me as a fellow in cardiology in '56. I spent a year after that in Don Gregg's lab in cardiovascular research. And then they figured I hadn't learned enough, and I was assistant chief of cardiology for 3 more years with Tom Inman and Weldon Walker, who were both outstanding cardiologists. So I sort of had a 5-year fellowship, except only one really counted. Tom's interests were in stress testing, ECG changes of coronary disease, cardiomyopathy, primary pulmonary hypertension, and was a wonderful, wonderful person. He even before I got back there as a fellow, he was involved in the care of Dwight D. Eisenhower with his acute myocardial infarction in '55. In that same year, Lyndon Johnson in the Senate had a myocardial infarction also. Both recovered. Ike and Paul Dudley White attended Ike. Paul Dudley White did a lot of campaigning for Ike not to go for re-election, to become a banner for peace, to work for the Heart Association. And Paul Dudley White, I think, had a lot of personal interest in what he was trying to manipulate Ike in doing. On the other side, I think Tom Mattingly probably personally agreed that Ike probably would be better off not subjecting himself to 4 more years, but allowed that Ike had to make the decision and presented the facts as they were then known. And Ike did decide to run for re-election in 1956, and he was elected for a 2nd term. In Gregg's lab, I want to demonstrate to you that we did the first coronary bypasses with the internal mammary coronary artery. We were putting flow meters on coronary arteries, except they were too big, and they eroded through the coronary arteries in a day or 2, and the dogs all died. So Don Gregg said we've got to create an anastomosis with some length that we can put the flow meter on, and we proceeded to develop a sutureless technique. Really not developed, it was used by some others before, and we modified it for inserting very quickly the stented end of the internal mammary into the now opened circumflex, and plug it in and tie it, and you've got an anastomosis made in about 1 minute. I had invited surgeons to come and do this for us first, and all their dogs died, and most of mine survived, so we fired the surgeons. This is at about 1 minute, this is the extreme of coronary occlusion, and you can see the epicardial current of injury, about 10 millimeters of ST segment elevation, and as soon as flow is restored, the STs are back to normal. This is the coronary angiogram at about 7 days, and this is about 5 or 6 weeks, and you can see that we had very excellent results. We use them for flow studies on the dogs, and this is just an example of reactive hyperemia. Flow control, 34 cc's a minute. You turn it off for about 15 seconds, and then you turn it back on, and it triples. And Don Gregg said to me, Bob, if we could find out what causes that vasodilatation and bottle it, we'd make a lot of money and probably win a Nobel Prize. Well, you know now it's endothelial-derived relaxing factor, EDRF, or NO, nitrous oxide. But we didn't know what it was then. We just knew that if you clamped the coronary and then you let it loose, it just dilated the bejesus out of that distal vessel, and flow looked great. And you can see that flow is mainly diastolic. About this time, Saul Sherry and Fletcher, knowing in their mind that acute myocardial infarction was a thrombotic occlusion in the coronary artery, created what they called a massive and prolonged thrombolytic state with streptokinase and tried to dissolve the clot. Their only problem is these studies were basically negative because they started too late. The destruction of the total occlusion on the myocardium had occurred. They probably dissolved the clots out, but it was too late. I just point out that the computer chip was invented by Jack Kilby in Dallas, Texas in September 1958. In 58, Mason Soames invented serendipitously coronary angiography. He thought he was injecting into the aortic root. The catheter was in the tip of the left main coronary artery on a 14-year-old boy, and when he pulled the trigger, the coronaries lit up, and he thought he had killed the patient. Nothing happened. So he very carefully began to pursue that as a technique of selective opacification of the coronary arteries. And in 1959, at an American Heart meeting in a small room, they always put the important things that you want to hear about in a small room, and there's no room to sit, stand, or even get near the presentation. But at the top arrow, he presented 50 patients, and some of the things that struck him, he found normal coronary arteries in some people that had symptoms that strongly suggested coronary disease. Well, isn't that a surprise? You and I know that. We see it every day. He found complete occlusion sometimes of one or two great vessels, and he found collaterals between one vessel bed and another. He was making discoveries left and right. And then he concludes by saying the ultimate usefulness of this method remains to be defined. He was being conservative. But his preaching was that everyone deserved to have a coronary angiogram. He even did one on his mother, and she had V-fib, and he had a shocker. And he finally had one done on himself. Paul Zoll invented the external ventricular defibrillator, enabling one now to shock the heart through the chest wall. And we awarded the Ray C. Fish Award and Texas Heart Institute Medal to Paul Zoll in '81. At the same time, back in '60, Keuenhoven and Jude. See, no one remembers Ing and Knickerbocker. When you talk about closed chest massage, you talk about Keuenhoven and Jude. And the second guy and the fourth guy get left out. They just weren't you don't remember them. But they showed that you could keep circulation going with closed chest massage. Bernie Lone terminated cardiac arrhythmias with external synchronized capacitor discharge, and Hughes Day put it all together and developed his first coronary intensive care area in Kansas City, Kansas, putting these things together with a monitor saying if we can do something about these dysrhythmias, let's put the people that are having them in one place where we can watch them and save their life. I had the good fortune of serving in Brooke General Hospital in this great state of Texas, and then for 3 more years at Walter Reed. But it was 5 years up here at Fort Sam that made me fall in love with the state of Texas, with its ethic, its mores, and damn that thing, there it goes. You move your hand around and some little window pops up on you, sensitive screens. But I'm not doing bad, am I? That's only one time so far. Michael Grad would have this, and Terry Ferguson, would have these things dancing, but I haven't gotten that far yet. So it was 5 years at Fort Sam that made me, I met Denton there, Larry Lamb, I got to know other people down here in Houston, and made me decide that San Antonio was not the place to end up my life. Washington was not, but to come back for my next career here in Houston. That war in Vietnam that I didn't talk about was the longest war that we had. It was the most divisive, most unpopular war, and it created riots in college campuses, riots in the city of Washington and other great cities. There were both riots against the war and race riots all mixed together. Ike was in the hospital with his 3rd myocardial infarction at that time, and he would cringe when he heard the morning news. It made his VPCs just jump and double and triple. It was terrible. That little war in Vietnam resulted in another 58,000 Americans dead. The war spanned three presidents, Kennedy, Johnson, and Nixon, but Johnson threw the most effort into it. He tried to supply butter at home and guns in the field, and it didn't work. Under the guise of an incident in Tonkin Bay, he signed the Tonkin Bay Resolution in '64 and really accelerated the war. He also accelerated our life by signing Medicare July 30th, 1965. It's interesting to see Harry Truman still looking pretty good at that time. He was in his 80s, waving pens around. The further attack on blood vessels is now in the hands of Charlie Dotter, and he began dilating coronary vessels, peripheral vascular vessels, and described a technique of doing this. Actually, it was precipitated by his mistakenly pushing a stiff catheter through an atherosclerotic lesion, and the lesion opened up. That technique is now called dottering. It's a shame that one person who's contributed so much is remembered only as a verb, to dotter or dottering, and that's what he's in memory for. He, in one of his articles, said, "One man's complication is another man's therapy." He was perceptive enough to say in '66, "We hope that someday simple proximal dilatation will be given a long overdue trial in the management of acute and chronic coronary disease." And here's a little device he invented to put in a plugged peripheral vessel and push it in and dilate it and leave the little mechanical device there as a stent. It was not an expandable stent, and I bet a lot of junk went downstream, but it did keep the vessel open. A year later, Bill Rashkin became the father of interventional cardiology when he invented the process of balloon dilatation of the atrial septum. Children born with complete transposition need a communication between the right and left circuit, and the impediment to that is the almost intact in many atrial septums, and surgically treating that and opening the septum was quite risky, and he invented the balloon technique and became the first per catheter interventionalist in little kids that might only be days or weeks old. Charlie Judkin invented the femoral technique of approaching the vascular system. Until then, Soanes's technique was that of a cut down to the brachial artery. I think Judkins wasn't doing much work because the patient's head's here and the arm's here. He's a long way from the femoral approach. It's down at the other end. There's probably an intern doing that. I've mentioned Dwight D. Eisenhower running for a second term after his heart attacks. I knew of him then only through Tom Mattingly, never had the occasion to see him until March of 1968, at which time I was at Walter Reed, and I was called by Leonard Heaton, the Surgeon General, and asked to go to California, that Ike had had an acute myocardial infarction at Palm Desert. After we stabilized him, he was brought back with us on Air Force One to Walter Reed. He had another heart attack right in the middle of my wife's birthday celebration in June of '68, and a third cataclysmic one during grand rounds in August of 1968, the latter depicted here with V-fib and counter shock. He was repeatedly shocked or spontaneously converted about 72 times in the next week, and ultimately died of severe coronary disease in March of the following year, about a year after his initial second major myocardial infarction. I left the Army in '69. I was fortunate to be asked by Denton Cooley to come here. I arrived in early August in a maelstrom of controversy over the implantation of the first total artificial heart in Mr. Karp. This prompted Dr. DeBakey to request Dr. Cooley get out of the medical society and off Baylor, et cetera, et cetera. The artificial heart was followed 2 days later by a heart transplant. It was quite the experience for those who are here, and when I came in August, I wondered, boy, what have I gotten into? Fortunately, I joined outstandingly good surgeons. They got very high marks and did great work, and it was easy to be a good cardiologist in an invasive world if you had good surgeons. This was a time when coronary bypass surgery began. Almost simultaneously, two papers, one by Fabioro, one by Dudley Johnson, describing saphenous vein grafts to the occluded coronary arteries, and a whole new surgical enterprise was born. Coronary angiography permitted us to risk stratify patients based on the severity of coronary disease. What happens when you get excited, you push too many buttons. But if you look here, if you got single, double, triple, and main left, the more coronary disease you have, the steeper down is your slope of life. And if you look at 5 years, everyone is down below 80%. After bypass surgery, you stack people up by the extent of coronary disease, and everyone in the 5 years has about a 90% survival. In other words, the worst cases have been pushed upward and are equal to the single vessel disease. Very convincing evidence, we thought, that coronary bypass surgery indeed was not only treatment for the symptoms of angina, but did prolong life, and multiple papers since that have proven the same point. Herrick very early told us that acute myocardial infarction was a coronary artery thrombus, but over the subsequent 60-odd years, the argument continued to wage, was the coronary thrombus primary, or did it merely come on later on after the coronary narrowed down and it was a secondary event? There were many that did propose that it was a secondary event that were still publishing in the early 70s. Prince metal angina was solved. We began to understand it in the 70s, and here's an example of a vessel with some disease and vasospastically occluded. You can see it's occluded, and then with nitroglycerin reopened. Excuse me. In the mid-70s, Grunzig, working in Europe, little gin and water. Working in Europe, was working with, at first, personally manufactured balloon catheters. And this is his first presentation at an American Heart Meeting in this country, which was of animal studies with dilatation with balloon catheters. He started in the periphery, worked up to the renal arteries and then to the coronaries. And in September 1977, he dilated the first left anterior descending coronary artery, opening it from about 90% occlusion to about 30%. That opened a whole new era of mechanical treatment of coronary disease. We were fortunate to have Grunzig here in '83 and presented to him the THI medal, and he was a very gracious recipient. This was his presentation at the American Heart Association meeting in 1979, and he presented on his first 50 patients. He describes opening successful in 32 out of 50, opening the occlusion from about 84% to 34%. 5 patients had early reocclusion and had to be taken to surgery. He conducted about 4 or 5 courses in Zurich, and then came to America, settling down in Atlanta with Willis Hurst and the gang. I've always thought this was Angelini in the front row, but Paulo tells me that's not he. That Paulo went to one of the courses in Atlanta, but did not go to the one in Zurich. I can't recognize anyone else in that blurred picture, fortunately. Who? Who's there? You're there. Where are you? Second row. See, you got so much hair then, I don't recognize you. You guys show me that on the original, on the picture. That's wonderful. At this time, there was a tendency to use surgical revascularization for acute myocardial infarction, and there was a number of papers presented surgical emergency coronary bypass for acute infarct, surgical management of acute infarct. And it was in this setting of getting people to surgery quickly for bypass that Marcus DeWood, who was just a young kid at the time, he was an intern or first-year resident, was involved in helping with these coronary angiograms that were being done for the surgeon. And he recognized that if you did the angiogram very early, there was a clot in the coronary artery. And the longer you waited, the ones who were angioed hours and hours later had much less clot. So he said, you know, clot must be the de novo initiating event. And that stimulated Ganz in California and Rentrup in Europe to go back to streptokinase, but now squirted into the coronaries directly through a catheter. And here's from Gantz's article in '81, the occluded right coronary artery, he pushes the wire in, then squirts some thrombolytic in, and the vessel opens. Born the new period of thrombolytic therapy. Rentrup showed the same thing in Europe, and here you can see the occluded vessel, and there it's been opened with direct installation of thrombolytic. Now, '85 to us cardiologists was a terrible year. In a period of 9 months, 4 legends in cardiology all died. Dotter, Sohns, Judkins, Grunzig. Sohns of too many cigarettes. I don't know what Dotter died of. Grunzig of his own success. He flew his airplane into a mountain. And I don't know what Judkins died of, probably coronary disease. At just about this time, Schatz began using expandable stents in San Antonio in dogs. And Ulrich Sigvart, who trained some of his training here with Jim Alexander in the Baylor system, began to use intravascular stents in preventing restenosis after transluminal angioplasty. It became obvious when the two techniques were compared that the expandable stent was more favorable than angioplasty alone, and the world of stents grew. At the same time, although the Pentagon and the United States Army invented all these letters, the medical literature copied it. We had Giese, Timmy, Gusto, Pammy, and there's so many that I can't remember who's who. But they are scattered through the 80s and the 90s and are part of the evolution of what we have learned in the last 2 decades. If you look at the Giese study in '87, it demonstrates that you have a better survival if you receive intravenous streptokinase, and the best survival compared to the control if you get it very early. TPA compared to streptokinase clearly showed that TPA was superior. The TIMI trials showed that the better you open the vessel, the better the grade of TIMI flow, the lower the mortality of an infarct, and the sooner you got to the patient, the earlier you administered therapy, the better the survival or the lower the mortality. We take all these things for granted, but they were coming out left and right from these multi-lettered trials in the 80s and early 90s. Terry Ferguson makes a living on all those names, and I just have trouble remembering them. The latest is the drug-eluting stent, and it's interesting that of our faculty, the doctor who's most interested, Emerson Perrin, obviously has a pseudo-doc, another Perrin, involved in this laboratory in Netherlands on the drug-eluting stents, which elude rapamycin or sirolimus, which is a anti-growth substance, and it's very clear that you can see there's only about 120 patients on each side, but if you look at the target vessel revascularization, here's the group that just got the ordinary stent, 27 needed something again done because of restenosis, 0 in the drug-eluting stent. And this one, if you can see the line, I can barely see it, but this is the event-free survival curve of the drug-eluting stents and the standard stents. And obviously, this is the wave of the future. If you're going to get a stent, you want one that eludes something which will prevent restenosis. Other important things that have happened in the last half of the century, diuretics. I started practicing cardiology treating heart failure with mercurials injected intravenously and intermuscularly. The first oral chlorothiazide came out in the 50s. I was advised by someone who worked with Merck to buy some shares in Merck because this was going to be the greatest thing that hit since Shinola. And of course, on Major's salary, I had very little to invest in Merck Sharp and Dome, and I let that go by. Merck's present value, although it's half of what it was at its peak, if you tracked it back, was worth about 5 cents a share at the time I was advised to buy some Merck. If I had bought a couple thousand shares, I wouldn't have to be here lecturing today. Out on the golf course a long time ago. ACE inhibitors, angiotensin receptor blockers, statin drugs, these have all made a great contribution to our armamentarium, our medical management of patients. We commonly in conference think back that we used to see frequently left ventricular aneurysms, big apical aneurysms that resulted from total occlusion of usually the LAD. We hardly ever see an apical aneurysm anymore. We have gotten so much better at preventing the severe damage to the myocardium, at preventing remodeling, and by doing stuff with statin drugs that prevent recurrences and primary events in coronary disease. Now this will shock some of you because you know this medical center like it looks today, and you are looking down past, of course, the important thing, our St. Luke's Medical Tower building, with Maine and Fannin bracketing it, but go just back 50 years and all this there is the Shamrock Hilton. Fannin didn't even get beyond Holcomb. It ran into something, I don't know what the heck that was, a baseball field or something. But Maine went all the way down, Holcomb went across, and I think parts of the Herman Hospital structure are down there. So nothing sat here in this medical center half a century ago. So you are the recipients not only of vast progress in this medical center, but of vast progress in medicine and cardiology. It's hard to imagine what has occurred. It's hard to imagine what we didn't have 50 years ago, which is now present and at your disposal. I showed this slide at the very beginning, and indeed I hope I've convinced you that there has been a rapid growth of knowledge and of technology. I began my career in the middle of World War II. I seem to be ending it in the middle of another war, a totally different kind of war. But we lost more people on September 11, 2001 than were lost on that first day at Pearl Harbor on December 7th, 1941. So I'll close by thanking you all for coming to this celebration, as it were, of my retirement.